Today's webinar will be presented by Dr. David Adam. David graduated from the University of Western Australia in 2010 and undertook general practice training at Lockridge Medical Centre. After completing postgraduate training, he returned to Lockridge in 2016. He is particularly interested in children's health and medical education. David is a member of the Practice Technology and Management RACGP Expert Committee and presented workshops as a digital champion to members as part of the 2018 My Health Record Education Awareness Program. Before being a GP, David was an IT systems administrator. David, welcome to the webinar.
Thanks, Sally. Glad to be here.
Thanks. David, myself and the RACGP would like to thank everyone today for taking time out of your busy schedules to participate in today's webinar. We look forward to engaging you in today's webinar, and while you may feel like you are the only one participating at the moment, you are joined online by a number of your peers, as well as other eHealth experts that will be available at the end of the webinar to assist David to answer your questions. Before we begin, I would like to make an acknowledgement to country. I would like to acknowledge the traditional owners of the respective lands on which we are meeting today and pay my respects to elders past and present. I would also like to acknowledge any Aboriginal and Torres Strait Islander people present. I'll hand it over to you.
Oh, thanks very much, Sally. It's really great to see such a diverse mix of people joining us today as well. We normally feel like we're mostly talking to doctors, but I think it's good to see so many people from a broad range of backgrounds are interested. As you know, health record quality affects us all. Over the course of today, we will try and fulfil the learning outcomes you can see on screen. And to do that, we'll run through a few things. So on the agenda, which you'll see on the next slide, we're going to talk about health data collection and storage in general practice, some of the rationale between why good quality data is needed, particularly in electronic medical records, and some of the issues that can come up. I'd like to take you through the college's resource that they put together called Improving Health Record Quality in General Practice, which looks at the attributes of high quality data in good health records and also some tips for improving it in your practice or in the practices you support. And then we'll have some time for questions and answers. So I think most of us who are doctors and nurses learn pretty much from the get-go. You know, it was drilled into us that if it wasn't written down, it might as well not have happened. And really, health records are about supporting our clinical decisions and our day-to-day practice. The RACGP standards for general practices contain a number of core standards, and one of them is the content of patient health records. Good records improve patient safety and well-being by supporting clinical decision-making, and I'm sure we've all experienced times when a good record has made it easy to access information, things like patients' allergies and patients' medical history, as well as that consultation notes and patient health records are a really important part of our risk management. I know several medical defence organisations have identified, failure to follow up matters that patients have previously raised, and the significant risk that can pose to practices and practitioners. So the college standards, the 5th edition, which is the most recent version produced, have core standard 7, which say that our patient health records contain an accurate and comprehensive record of all interactions with our patients. There is significant detail under that standard, and for example, criterion 7.1 explores the content of the patient health records, about when they're updated, about the person making the entry, and the legibility of the record. That, I think, is something that we had hoped would really improve with electronic medical records, but of course we've gone from problems with not being able to read doctors' writing to now not understanding the myriad of abbreviations that we all like to use, and certainly some of us are more used to lots of typing than others. It's occasionally very interesting to pull the paper records that we still hold in the archives from before we went digital 20 years ago. I think that some things have changed and some things have stayed very much the same. The standards explore in detail what needs to be in a medical record, and that's things like, the date, the name of the person consulting it, the method of communication, whether that's a home visit or a phone call, the clinical findings, the diagnosis you've made if you have, and management plans, medicines prescribed, other directions given, and the patient consent for things like third parties in the practice. The standards also talk about coding of diagnosis, which is an area that many people struggle with, I think, and then explores some of the other information that can be contained within the record. While we're talking about the RACGP standards, I'd also like to call attention to one of the new areas in the 5th edition. One of the overarching statements of the standards is that businesses need to operate successfully to create an environment where quality clinical care can be delivered. And to operate a business successfully, strategic thinking and business planning is just as important as financial budgeting and reporting. To assist with this, there's a new quality improvement module in the 5th edition standards. And the indicators that are contained within that criterion are displayed on the screen now. There's also some examples in the standards themselves about how you in your practice can plan and set business goals, evaluate your progress and risk management. Now, the reason we're bringing this up is that data quality can often be an important part of quality improvement. And in fact, many of the things that we're going to talk about later on in the day about how to improve the quality of your health records feed directly into this accreditation quality improvement idea. So to summarise, from our resource that we're going to look at later, the primary purpose of a clinical health record is to hold the information about a patient that's required for effective care. Good patient information supports appropriate clinical decisions. And we can break that down a little further. The first is that our record, number one, supports safe clinical decision making. This is both a part of risk minimisation, prevention of problems, and as well as improving patient safety, and meaning that your practice is meeting accreditation standards. For those of us that work in big practices or who are using various electronic communication tools, a good record makes good communication easy. It saves time and it provides useful information to our colleagues, whether they are in our practice, outside or outside our practice. And it facilitates continuity of quality patient care. A good health summary and a good background information helps clinicians provide safe and effective care. And this helps reassure our patients as well, that they feel like, many people will have complained that they feel like they tell people the same things over and over and over. And I'm sure we've all had moments where knowing something on the patient's record has saved our bacon and helped our relationship with our patient. And finally, on a financial level, on a practice level, a good quality record can really support sustainability in your practice, whether that's through accreditation or eligibility for patient runs. So we're going to put a poll together now, and we'd like you to think about. Oh, sorry, I'll let Sally take over.
That's all right. We just wanted to know how would you rate your practice's ability to maintain high quality health records? Is it excellent and maintained at a consistently high standard, a high standard but could have some minor improvements, acceptable but requires further improvements, unacceptable and requires significant improvements, or not applicable? So I'll just give it a couple more seconds. And I'll just close that off and share it with you all now. So we had 0% excellent, David.
Yeah, and I think that reflects the inherent difficulty in doing everything absolutely right all the time, especially in our current environment, the kind of software that we're using. I think it's also helpful to realise that we could always be doing something a bit better, and I think that partly reflects that. I sometimes talk about the amoxicillin index, which is a totally unscientific and unpublished idea, but what you do is you ask your practice manager or whoever drives the auditing system in your practice to tell you how many patients in your record have a long-term medication of amoxicillin entered against their record. There are many people there are always a few people who should be on it long-term, but most of the time we find that an entry in the long-term medications list of an antibiotic is a mistake. And I think that can be a useful guide to just as a broad indicator of how good quality your health records are. So, for example, we've got about 12 or 15,000 patients on the books, and we have about 30 of them have a long-term medicine prescribed of Amoxil. Most of those were in the late 90s or early 2000s. And so there's some good examples of records that clearly haven't been kept up to date. And that takes me on to our next slide, which is a comment from a paper from the New England Journal of Medicine, which says that the record should not be right only. So they've said that data by itself or data by themselves is useless, and to be useful, you have to be able to analyse it, interpret, and act upon it. And I think that's a good reminder to us that we're not just writing for the sake of writing. We're not interested in just getting it on the paper to get it out of our heads. We need to be able to use that information in the future, whether that's for clinical or risk management or medical legal purposes or for further analysis. So some of the issues that we have with health records, some of the things that make it challenging to keep your record high quality really often come down to a lack of time, with busy clinicians, and a lack of training. But some of the issues that can come up include underreporting, so we forget to write it down, or it might be missing, as in we haven't asked about it, so we can't fill it in. If data is recorded as a free text sort of entry or structured data, that can cause some issues with either being not specific enough or too specific. I certainly remember working in emergency where every diagnosis had to be coded, and there just weren't codes for a lot of things. So there are a number of people in southwest Western Australia who were diagnosed with a crocodile bite because that was our sort of catch-all term for things that didn't fit into the coding system. And so this can certainly give people problems with data collection. At the same time, free text doesn't always give you the right answers either. I've seen several patients in our record where the smoking status is recorded as stopped several years ago, but there's no entry, there's no idea of when that entry was made. So was that 25 years ago when we first went to an electronic medical record, or was it yesterday when the patient presented? I've certainly encountered differences in measurements or in recording or in the clinical focus, which, exactly what you're thinking about on the day when you're typing things into the system can make things duplicated or be incorrect. And of course, the coding systems that we use can be incomplete or inaccurate. Again, to use that crocodile bite example. The other problem we have in Australia is that just about every major software package in primary care uses a slightly different coding system. And by that, I mean what each diagnosis is represented as. So if I'm using best practice and I put someone having an ERTI, that might be code A32, but then I go over to MedCheck and an ERTI is a J05519 or whatever, and those codes are obviously inconsistent. They don't work together. So we're going to put again something up on the screen about what you find the most challenging factor in maintaining high quality records within your practices.
Yes, thanks, David. So we've got lack of time or training, lack of practice, support, improvement culture, all of the above, none of the above or unsure, or not applicable. So if everyone could pick an answer, that would be great. And I'll just give it a couple more seconds. And share it with you all. So we've got lack of time or training.
Yep. So lack of time is and both, I guess, is the big answer there, isn't it? These barriers affect us all. Time is a big problem. When I first interviewed for my general practice role, my supervisor at the time asked me what my greatest weakness was, and I didn't really have a prepared answer. So I said time management, and as soon as it came out of my mouth, I thought, why on earth did I say that? That's a terrible answer for someone who wants to be a GP. But everyone in the room laughed and they said, no, you think you're bad at time management until you start in general practice, and then you realise just how tough it is. So I think time is a big problem for us all. Today we're going to look at some of these ways of managing these issues and how to maintain high quality data going into the practice. I'd like to talk briefly about the way general practice health records are changing in the current day and age. And this is, I guess, another reason where having good quality records can really support us. Many of us will remember the paper record where you had a file, or in some cases 2 or 3 files, with a number of scraps of paper in them. We had our RACGP front sheet at the beginning, which we hopefully kept up to date in pencil or with pen and whiteout. Most practices, in fact, the overwhelming majority of practices in Australia now use electronic records, but we still have the same problems where some of this information is contained within silos. So my practice system doesn't necessarily talk to anyone else's practice system, and they certainly have real difficulty communicating with hospital systems, with third-party providers, and even with patients. So although there is some limited electronic transfer of records, it is still very self-contained. And we have more information. I certainly think we collect a lot more information, and partly that's that things are more available, but investigations are easier and cheaper and quicker. Because we've got the typing system and most of us can type fairly quickly, that it's easier for us to write longer entries, and that the culture around what we write in the notes is changing. 25 years ago, it was acceptable to write, 25-year-old male, 30, reassured, and then a signature. I think in this day and age, you would struggle to defend yourself if that person turned out to actually be sicker than your assessment had made them out to be. What we are moving towards, though, is a shared electronic record. And I would say we have limited shared records with things like the My Health record system. Now, since the opt-out changes at the beginning of the year, about 90% of Australians or more have a My Health record. And what we've seen in our education around this is that it's easy for GPs to participate in the My Health record system if their data is already good quality, if their practices are already keeping good records. It's actually really straightforward to share data with systems like the My Health record. And certainly the RACGP as a professional body advocates for the implementation of systems and processes and support things like My Health record data quality and then minimise the administrative and regulatory burden on general practice. So we would say that, to support something like My Health record, we need to be doing things that support good quality in our own practices. To this end, the RACGP has produced a significant resource called Improving Health Record Quality in General Practice. And this is a free document that's available on the RACGP's website. The reason that we put this together is to support practices in making and maintaining good quality health records because of those benefits that we've talked about appropriate decision making and continuity of care, and especially with the increasing use of shared care models and the introduction of the National Health Record. Again, just to reiterate, the maintenance of good quality health records in general practice contributes also to secondary use, so that's data provision for research and policy, to education within the practice, and for medical legal purposes. So the RACGP's guide outlines what constitutes a high quality health record and how practices can put systems in place to ensure that they produce health records that are useful, that are fit for purpose. We'll send you through a message with the link to it in your message box, and we're now just going to step through it and you'll see what sort of information it contains. So the guide focuses on the 6 attributes of high quality health records and gives you guidance about how practices can achieve these, including how to set up health record systems that facilitates the production of high quality health records. Tips and case studies are included throughout to give practical information, and the attributes of health records that are presented align with the Medical Board of Australia's Code of Conduct around how Australian doctors should maintain their records, and that's section 8.4 of the Good Medical Practice Guide. We have tried not to, in fact, we haven't imposed new obligations over the current RACGP standards, and in fact, you'll see it linking back several times to the 5th edition standards with that little flag that you can see on your screen there. Of course, the guide is fairly general in nature. We've written it to be applicable to general practice across Australia. And so you will also need to be aware of existing legislation, codes of conduct, local professional standards and clinical guidelines, and the existing policies that are relevant to your discipline or organisation within the primary healthcare sector. And to give you an example, what needs to be in the record in, for example, a detention facility or the judicial system may look different to what you need in a cottage general practice in the suburb of Perth. In all instances where the guide refers to the sharing of health information, what we're trying to cover is the use and disclosure of information by general practices and by doctors, and includes circumstances where that disclosure is required or authorised by law. So where you need to use or disclose information to lessen or prevent serious threats to life or safety. It talks about patient consent, whether that's express or implied, to the collection and use and disclosure of health information. And there's also some information about a patient's right to access their own health information, and includes the circumstances where denying access to that is required or authorised under law. So, for example, access to the information would pose a serious threat to the life or health of an individual. So, the quality of health records kept by general practices, as we've already described, is critical. And this is even more the case as patient health records are increasingly shared with other health practitioners. And so the first part of the guide talks about the rationale, and many of these things we've already covered, about safe decision making, good communication, good partnerships with patients, and making continuity of care easy. I work in a reasonable sized practice where we have a fairly frequent turnover of registrars, most of whom stay with us for a year, but many of our patients have been with us for 35 or 40 years. And so they can become a little disillusioned or a little frustrated when they see a new doctor year on year. If we avoid asking them the same questions over again, and if we all have an awareness of the problems that they've had in the past, that helps build rapport with them and make our lives and their lives much easier. And of course, as we said earlier, good records provide evidence of care. So again and again in medical legal cases, if records are complete and demonstrate comprehensive care, that is enormously helpful should a complaint be made against you. A number of coronial reports I've read have called out the quality or lack of quality in people's recording of decisions across all sectors, whether that's general practitioners, hospital doctors, nurses, pharmacists, or others. We are, of course, no longer producing health records for the benefit of just ourselves or ourselves in the future. So Sally's going to put another poll together about what you've found good quality health records to help you with.
Yes, thanks, David. The question is, or the statement is, I've used good quality records too, and please answer as many as are relevant to you. So the options are to avoid unnecessary investigations, connect to my health record easily, analyse my practice population, communicate with other practitioners, and support patients with a chronic illness. So yes, select as many as are relevant to you. And I'll just give everyone a couple more seconds to vote. And I'll just close it off and share it with you all.
Yeah, so that's great. So it's good to see that some people are seeing some benefits from good quality records. I see the lowest number there is against connecting to my health records. So less than 50% of people have found that good quality records help them connect to my health record. When I do the training with our registrars about how to create things like shared health summaries, what we see over and over is that it's a really easy process. It takes about 30 seconds if the person already has a good quality record, so that their medical history and classifications are up to date, their medication list has been maintained, and you've tidied up their immunisations and their drug allergy list. All software is different, but ours makes that very straightforward. It's about 7 clicks as long as you don't need to amend anything. All of us have seen referral letters that have, in communicating with other health practitioners, all of us have seen referral letters that are missing critical diagnoses, or contain information that's irrelevant. And so I think we've all seen then the benefit of good quality records in communicating with other practitioners. So we've talked a lot about the benefits, and I think we're all on the same page about why they're important. Let's talk about what makes a good record. And there are 6 attributes of quality that the guide focuses on. You'll see them on your screen now. So data needs to be accurate. It needs to and that means it needs to correctly reflect what was said and what was done in the consultation. It needs to be complete. It needs to be sufficient for the range of purposes that we need it for. It needs to be consistent so that we use standardised terminology and a recognised coding system to complement the free text narrative. That's important because it helps support many of those processes that we've talked about. I certainly know in our practice we have, for historical reasons, 2 codes for type 2 diabetes, and people always pick the old one first, which is impossible to use as effectively as the new code. So consistency is really key. It needs to be legible. It needs to be easy to read and understand. If you've imported doctors from, for example, the NHS refugees that seem to be flooding through on an ongoing basis, they seem to have a whole new set of abbreviations. And I know when I worked with some English doctors, I was constantly going to them asking, well, what does this mean? What does this mean? They have the same problems when they come to Australia, of course. We use abbreviations or we use terms of phrase that they don't understand. So it's really important that we are clear, not just that our writing is easy to understand and it's not filled with typos, but that we're using words that we can understand each other. I don't know that there's many general practices that are still doing lots of scanning of handwritten notes. The area we still do that in is for home visits, where our doctors go out and write notes in pen and paper, and then it's scanned in later. But really, the scanning of third-party information, so information you've had faxed or posted to you, it's really important to ensure that's legible. And again, I'm sure we've all seen cases where that's been a problem. It needs to be accessible, and this is often where your software does the heavy lifting, in making information arranged in ways that make it readily retrievable, as well as understandable and meaningful to other people. And finally, it needs to be up to date. It needs to be relevant to what was captured in the consultation at the time. So it's not very useful to have a consultation done and then you write the notes 6 weeks later, because obviously things aren't going to slip through your mind, and people may make decisions in the interim based on the incomplete information that we've got available to them. And again, this is another area that I'm sure we've all experienced. You send a patient to see another doctor and you get a letter 6 weeks or even 6 months later about what happened to them during their admission to hospital. So we're going to look at each of these attributes in a little bit more detail and how that can be achieved. So they must be accurate. Health records are only as good as the quality of the information they contain. The RACGP in the standards document and in the guide suggests a number of attributes of high quality records, so how you know that your records are high quality. But at the end of the day, they should accurately and comprehensively record information that's captured about patients. Accuracy is critical to patient care, but of course our clinical information is at times uncertain or variable, and practitioners reach diagnoses and use variable clinical terms, particularly across disciplines. So we need to make sure and take time to ensure that our patient records correctly reflect demographic information, the information captured during consultation, and information collected from other sources. So some useful tips are to regularly check that patient contact details are up to date, and that's a really good thing for your front desk to be doing. There's no good printing a prescription and the patient looking at it and saying, well, hang on, that's not my address anymore. So our practice makes it routine to confirm that details are confirmed each time at the front desk. It's important to make sure that only authorised and properly trained team members can access and alter the patient clinical records. When we are conducting consultations either in person or by phone or by telehealth or other means, it's important that we confirm identities and that we've got the right record open. And I think most of us will have had at least one experience in their life where they start typing and they realise that actually the person in front of them is 20 years older than what the record says, and they've had a whole bunch of problems with that on the list, and actually we've opened someone else by the same name. It can be helpful as part of your usual clinical risk management to record and review near misses regarding incorrect or inaccurate incorporation of patient information into the records. And there are standards or indicators for accuracy in the 5th edition standard. Records should be complete. So they must contain sufficient information to serve a range of purposes, and some of those we've discussed already. So that includes information that's collected by the practice and information from other sources. We need to consider the various different purposes of health records when recording information during a consultation, and we need to keep in mind that in the current climate that we should expect to share the information that is entered into the record. Now that may be sharing with the patient who has the right of access to their own record, or it may be sharing information with other people. So when you enter your diagnosis of ischemic heart disease or coronary artery bypass grafting, it's important to think about, well, what am I going to put in the annotation for that? Is it relevant to other doctors that they've had their graft done to their left internal mammary artery? Well, actually, it is important to the cardiologist or that you send them to see when they're travelling, or when their original cardiologist retires and takes all their records with them. The college standards, again, require patient records to contain a number of details, and that's focused in core standard 7 of the RACGP standards, which I won't go through again, although we mentioned some of those things earlier. Some of the ways you can ensure your record is complete is by using registration forms, either electronic or paper, so that you're getting all the information required about their demographics and their background, about having strong policies and checklists for procedures involved in managing health information from within the practice and from other sources. For example, you might say, well, if we're going to have a policy that if new patient information forms are returned incomplete, then there's a particular person whose job it is to follow up the patient or their doctor to complete the form. And always, recording information that you would find helpful. As I said earlier, think of the other doctors as well, or the locum when you go on holiday who takes over. Can they use your records to manage unfamiliar patients to them? And there's also some information in the guide about managing information that comes from other sources. Consistency. So again, we've mentioned that using recognised medical vocabulary, standard terms and abbreviations, and being consistent when recording diagnosis and observation procedures is essential. What it means is that records are usable by all health professionals who need to refer to a patient's health record, and that includes all members of your practice team, whether they are GPs, registrars, nurses, pharmacists, allied health providers. The other thing that it's useful for is about searching and analysis of your medical information. Most clinical information systems will contain a nationally recognised medical vocabulary or coding system or classification system. We use the ICPC system in our software. I think the Digital Health Agency is desperately trying to get everyone in Australia to move to something called SNOMED CT-AU, which they spent lots and lots of money and lots of doctors and non-doctors' time on. We're slowly getting there. But what that means is that those coding systems allow structured data entry for diagnosis and prescription pathology. At the same time, it's important for us to complement that with free text information to provide the narrative or the context for a patient's health information. But of course, many systems make that difficult to search, and ambiguity, if I write DM and you write diabetes mellitus, that can be harder to search for. So we encourage people to use them both. It's helpful to educate practice staff about the importance of entering information in a standardised way and provide training in how to take full advantage of the structured data entry that your clinical software provides. It can be good to have a standard idea of what, the usual terms and acronyms and abbreviations that are generally used by everyone are, and things that we will try and keep to a minimum. The one that often confuses my colleagues is an abbreviation that a former doctor in our practice used to use, which was ISQ for in status quo, or everything is stable. And we've agreed not to write that anymore and write what we think is stable, or what we think their progress is likely to be. Firstly, because it's more consistent and more easy to understand, and secondly, because it supports good decision making. It can be helpful to set up shortcuts or autocorrects to spell out the common abbreviations, and so you might write WNL, and that expands out to within normal limits. We do encourage people to be careful about using large blocks of copy-pasted information or autofill information, because it's generally very, very obvious that autofill information has been used, and it's more difficult to explain, should you be required to, why you didn't capture a particular piece of information. Again, find out what your software can do. Your clinical tools might help you collect consistent information from particular populations. For example, you might have a template for baby checks, or for screening for postnatal depression, or for your diabetes checks. So use your software to do as much of your heavy lifting as you can. If you're not sure how to do that, it's your software vendors would love to show you how to use it. You're paying them lots of money, and they would like you to get value for money out of their software. So legibility is the next criteria, about being easily read and understood. And as we said earlier, it's really important that data is presented in a way that's meaningful to other people, and that includes patients. We know that documenting healthcare records meaningfully can facilitate continuity of care and improve patient outcomes. Now, of course, the readability of your health records can be influenced by lots of factors, so keyboards and typing skills, how familiar you are with the software, things like quality of scanning, how forms are laid out, whether you're using paper forms or electronic forms, using the right fonts, using the right size font, the kind of language that you're using, and we've mentioned some of that before. So again, avoiding funny abbreviations or shorthand or jargon. Some people who are not strong typists prefer to use voice recognition software, and some of those work really well, and some of them have a little way to go. Certainly, a colleague of mine would use that fairly effectively, although occasionally you'd be getting halfway through a letter and you think, well, why is this word there? So if you are using dictation software, it's important to review the output of it. One way that's really helpful to ensure that the whole practice is fulfilling these requirements is by conducting peer review, or using your clinical meetings to review people's notes. And you'll see a quotation there from one of my colleagues on the expert committee for eHealth and practice systems, or technology and management, about how they review their records. Certainly, I think some of our more senior doctors struggle a little bit with the typing and the technological side of things. And most of our registrars probably have the opposite problem, where they write 600 lines for a patient who's come in with a sore throat or a runny nose. So I think there's a balance to be struck. And finally, not quite finally, but ultimately, accessible health information needs to be recorded in ways that make it easily retrievable. Almost all of us are using fully electronic systems, and in general, those are the best option for making information easily retrievable. Although, as we've sometimes seen, having too much information can make that difficult. One of the criticisms that's sometimes levelled against the My Health record system by some of my colleagues is that it makes it very easy to capture almost too much information. And so without effective filtering and searching capabilities, it can become overwhelming. And lastly, information should be recorded in patient health records in a timely manner. And I think it's fairly obvious to why that's required. Some of the tips in terms of making sure that can happen is to set aside time for doctors to maintain patient records, and that includes time to review information that needs to be entered from external sources, so whether that's catch-up spaces or making appointment time long enough for completing those. When I was studying for the OSCE, one of my supervisors said to me, you should be able to get everything done from a clinical point of view in 8 minutes, and the OSCE is not unreasonable with its time limit in that regard. And I said, that's not true. And he said, the most important thing is to not touch the computer until you're finished with the patient, because typing on your way through distracts you, or writing prescriptions or that kind of thing gets you distracted. He said you can take a history, examine, discuss the diagnosis, and come up with a management plan in 8 minutes for most people, which then gives you 4 minutes to type in your records, print your prescriptions, and write your notes, and write your X-ray forms, and then another few minutes to have the patient leave the room, take a breather, and call your next patient in. I don't know that that's possible in all practices, but it's certainly something worth striving for. So time management is important. It's helpful if your practice system can help you. So I know some software is better than others at this, but reminding the practice team to review smoking and drinking status rather than just setting it when you first see the patient, and then 20 years ago thinking, well, actually, are they still smoking? Of course, every practice is a little bit different. So some practices choose to focus on things for a month, to say we're going to review everyone's smoking status this month. Another example is on our case study on the next page. So this comes from one of my colleagues who helps to run a major metropolitan after-hours deputising service. And what would happen is that GPs at the beginning of the shift would be given 10 or more patients to triage and then prioritise and then visit. And what they found was that doctors were having trouble completing patient records because they sat down at the end of the shift to do all the records. Now, it might be 4, 5, 6 hours since the patient was actually seen before you sit down to write the notes, and there were a number of concerns about the completeness of information recorded this way, as I think you'll appreciate. The service changed its procedure so that each doctor received no more than 3 patients at a time to assess and visit, and then they were given time to complete their consultation notes before they got more patients. And so that's a fairly small but systematic change, and then they also introduced some audit, so making sure that internally they were looking at their patient records and making sure they were high quality. And what the service saw is that there was a significant improvement, and that was a comment from their own staff and also from external stakeholders, so people they were writing back to about their patients. So those are the qualities of good records. And we're going to run through some more of those ideas about how we can put that quality into practice. And the first thing is making it part of the practice culture. A key part of a practice's records keeping is the people who use it. And so we have to have buy-in from our staff. We need to know that effective record keeping must be prioritised and it must be routine. And for it to be routine, it's got to be of value. We've got to see that we get something out of it. So I really can't underestimate how important it is that your team feels like a good record is helpful to them. It requires strong leadership and it requires ongoing education and good workplace policies to support that. You might like to think about implementing a feedback process regarding health records to address problems raised by other healthcare professionals or other services or patients themselves. And as we mentioned earlier, it can be really important to keep track of near misses or mistakes in the incorporation of information to identify ways of preventing these from happening again. And you'll see our quote from one of our practice management members who talks about the induction process and really doing a good job of training them in using the system appropriately. To support that, we have systems and management approaches, so making sure that we have good practice policies and procedures and appropriate support systems. It might be helpful to have a particular team member delegated to manage the strategy and the overview of health records, while the practice management takes that overview of promoting high quality culture. For example, most clinical information systems have features that can help you audit the quality of health records, so tracking follow-up requests or recalls or reminders that haven't been actioned. And you may also be able to get a list of consultations where the diagnosis has not been coded, and that can help you talk to people about how many consultations they have that haven't been coded, and also to subsequently enter the right information. There are many policies and procedures that can help manage high quality record management, and that includes things about using the health record system, risk management, so ensuring information is entered into correct fields, and around system security. So some of you will have been to our previous webinar on information security in general practice, and the college has again put out a comprehensive document about how you can support that in your practice, and about how health record information is handled, so that how it comes into the practice, how it's managed within the practice, and how it's sent out to others, so whether that's to patients or to other clinicians. A good litmus test is how robust your procedure for handling INR management is. And I suppose with the new oral anticoagulants, the days of INRs are slowly becoming numbered. But our practice has a really robust system for making sure that when we receive an INR result, that a doctor is notified promptly, that they're given the result, that the result is followed up, and that the decision that's made about it is communicated to the patient. So that touches on all those areas, and it's a really good example of an area that needs strong policy and procedure behind it. Education and training, as we said at the beginning, is absolutely essential. So new members of staff, whether they are your registrars, new GPs, nurses, or administrative staff, need to understand how to use their system. They need to understand your goals with their health record and how important their contribution is to it. And they also need to know where they can get help. So if they don't know how to enter something or they don't know how to get something out of it, they need to know who to ask. Some people provide tip sheets or troubleshooting guides for common problems with the practice's clinical information system. But when you're talking to them, you need to really make sure you cover the key areas of the things that we've talked about today. They need to understand why it's important, the attributes of good records, and how to use the system effectively. So, for example, you might like to explore with your GPs what decision support tools are available in your current clinical information system. As we've touched on many times, it's not just the doctor sitting down with the patient who needs to work on good quality clinical records, and it's a whole of practice team that needs to be involved. You might like to make the quality of your record a focus of the practice team meeting, as we heard earlier from one of my colleagues. You might like to acknowledge or reward doctors who keep good records. You might like to agree with us on a standard terminology across disciplines, as we mentioned earlier. Allocating time, as we said earlier, is really important. And it's always important to be thinking about, what more can you do to help deliver high quality records? Are there checklists you need to be using? Do you need support from your clinical information vendor or from other outside staff? Can your primary health network help? Can software add-ons help? There's a lot of tools that are out there to help with this. Conduct regular audits, because we want to be making sure that we are doing the right thing rather than just hoping we're doing the right thing. And I would hope that if you're auditing, you would have had confidence in the answer that you gave us before about how often your record is really good quality. And that expect to share mindset that we talked about earlier, I think, is important. We sometimes see that in our, we've got a moderately sized group practice, and occasionally we get new doctors joining us from solo practices. And I think for a lot of the time they've been working, they've been working in practice where they don't have to share that information with anyone else. It's just an aid memoir for them. In our practice, we all work together and we understand that and the impact that has on our record quality. So just to summarise, we hope that you've learned a little bit today or been reminded a bit today about why we need good clinical records, particularly around safe decision-making and communication and continuity of care. We've given you some ideas about where and why data quality issues occur. We've run through those attributes of high-quality records and some ideas about putting that quality into practice. A quick word from our sponsors now. The RACGP's Practice Technology and Management Committee and Division produces a lot of resources that are available to you. And so the one that we've talked about today is just part of the picture. On the screen, you'll see some of the free resources that are available for download for anyone. And that includes things like the secondary use of general practice data. So once you've got good quality data, you might be tempted to use it for research or to bring other people in to help you analyse it. And some of the secondary use of information that you've collected poses significant issues. That document can really help. You'll also see our information security and general practice resource, which I referred to earlier. And there's our information about privacy, about managing health information in general practice. One of the biggest changes in health information that's come up in the last few years is what's called notifiable data breaches. So if for whatever reason you lose control of someone's information, what do you do now? What responsibilities and obligations do you have? The fact sheet on notifiable data breaches is your go-to there. And there's also a document that's been produced from our survey that we run every year, so you can find out what GPs' experiences are and what GPs think about the various technological things that are available to us today. The RACGP Expert Committee and eHealth experts will continue to conduct our eHealth webinar series through that 2019. And so coming up in July, we've got technology and general practice. and you'll see the other scheduled webinars that are on the screen. So you'll get sent a link through shortly that will have the future webinar series available, and certainly encourage you to attend those if that's something that you're interested in. So I hope that's been useful. We've got about 5 minutes now, I think, for questions. Is that right, Sally?
Yes, thanks for taking us through the information about improving data quality in general practice, David. So yeah, as promised, we now have time for Q&A. So if there's a question you had at all, please send it through. So we have had a couple of questions come through during the presentation, and one of them was, how long do I need to keep patient records for?
Yeah, and I'm going to have to quickly refer to my notes because this is one of those state-based things. In some states, there's legislation around that. So New South Wales, Victoria, and the Australian Capital Territory make it very clear the minimum time which medical records should be kept for is until the person is 25, if you got it when they were a child, if you collected that information when they were a child, or 7 years after the last occasion on which the health service was provided to the individual. So if you don't see someone for 7 years, then we would say that probably those records are acceptable to archive. In some cases, though, you'll see someone, you won't see them for 3, 4, maybe even 5 years. It's still important to keep those records from, when you saw them 25 years ago, if they are still it's still an active patient of the practice. Go ahead. Yep.
One we've had from the audience, sorry. Employees are easier to engage. How do you get contracted GPs to engage in contributing to a high quality record?
Yeah, that's a really good question. One thing that we have done, and I think it comes back firstly, I should say, to that idea of the practice culture. Are you a team or are you just a group of people sharing a building? So I think once contractors understand the benefits of good records and they experience the benefits from other people maintaining good records, I think that helps to create that buy-in. Now, in some cases, unit might need a little bit of an extra nudge, or whether that's that you get them to participate in audit, or you ask them to take on a role towards accreditation. Sometimes that involves a financial incentive as well. I know certainly our practice gives a small amount of money to whether they're contractors or employees of the practice who help maintain our My Health record, PRPs, standards, and make sure that our data quality is good there. So there's no one-size-fits-all answer for that, but I really think it comes back to teamwork. And when your contractors are interested in being part of a team, I think many things, as well as healthcare record quality, will improve.
Okay. So I think we have time for one more question. What about the legal dimension of a good EMR?
So we mentioned that a few times on the way through. I think it's the use of records in a legal sense is that they can really help you to understand your decision making and to help other people understand your decision making. So that means that in 5 or 7 or 8 years' time, when you're asked a question about a consultation, I can remember the consultations I did yesterday. Last week might be a bit of a struggle. 7 years ago is a write-out in almost all cases. So that's where your good record comes in. I don't know that there's anything particularly that you need to do to make your record good from a legal standpoint that doesn't also apply from a clinical standpoint. And I think you can be confident that, writing good notes if you do good medicine, the legal bit will look after itself. If you're making clear records, if you're doing all those other things that we've talked about, then I think it's unlikely that your records will be called into question, or that your decision making will be difficult to defend. So good electronic records make good clinical sense, and they also make good legal sense.
Okay. Well, thanks, David. That brings us to the end of today's webinar. Thanks for a great presentation.
All right, thanks for having me. And if you've got anyone that you'd like to send along, we're running again on Thursday.
Yes. Okay, so we hope you've enjoyed the presentation. If we didn't get to your questions today, please email the eHealth team on ehealth@racgp.org.au, and we'll get back to you as soon as we can. Thank you and goodbye.